So back we go out here. So these are the examples of these diseases, and this is not the class to discuss. The most common of them is probably still rheumatoid arthritis. We talked about an arthritis, and it's been studied a great deal about how this is. It's probably more, to me, it's more mediated by antibodies that circulate and leave deposits, as we commented on before, in joints. Myasthenia gravis, damage at the neuromuscular junction. Multiple sclerosis, attacking white matter. I wouldn't call it a link. There's an association with human herpes virus 6, which causes a disease called roseola, whether or not that's the cause. Graves' disease, hyperthyroidism. We talked about the type 1, and there's a lot of evidence to support that with diabetes. Lupus is probably if you take diabetes out of the picture, lupus is probably the second most common, and that's due to antigen antibody complexes finding their way into organs, and that's what it kind of leads to glomerulonephritis. We even see something like similar to that in certain ethnicities, one called sarcoidosis, which are really antigen antibody complexes. Very impactful here in Pittsburgh. Maybe the most famous mayor that we had in the last 60 years, Mayor Caligiuri, whose statue is out there. And we do see it in people of Mediterranean descent like he. And it's interesting, the mayor up, Lou Tullio, who's a mayor up in Erie, also Italian descent, succumbed to that same disease. Very, very interesting disease. And I've had a number of patients. So treatment, for years, it was very, very limited. Two items. You were people on steroids. There's a lot of complications with regard to chronic steroidal usage, number one. And number two, one that I take to this day called sulfasalazine, which they started me on when this reared its ugly head about, I don't know, 5-6 years ago. And that's been around forever. Those were the only treatments. We don't even know how the sulfasalazine works, but originally when people had that laundry list that was there, that was sort of like a go-to. And it's awful. I have to take 3 pills in the morning, 3 pills at night. And so basically treatment, try and find ways to suppress it, limit cytokine action, co-stimulatory molecules. Okay, can you activate regulatory cells, induce self-tolerance, etc.? There's different things. So autoimmune, weakly self-reactive lymphocytes that are activated by foreign antigens that resemble self-antigens, new genetic mutations, aptin, which are allergens, trauma, barriers. I mean, there's all sorts of incidents that could lead to this. So I don't put this in. I really focus on it more if we were doing a course really dedicated to immunological arthritides, then you would look more at what the causes and treatments are. But just to see that it's more common than you think. We're seeing a bit more of it today. I think there's environmental factors that play a role because I think it's exposure to toxins. I always wonder, I know it's a controversial topic, about the impact of vaccines. Because there's enough information to suggest that there's problems that are immunologically based associated with them. Maybe not as much as the anti-vax folks are, but some of their arguments have merit, I think. Hypersensitivities, allergies, basically. Unusual immune responses. You're going to see, and some of these diseases are characterized by this. So as we look at it, perceived that it should be harmless that do cause damage. And we distinguish them about how rapid they are and whether it's antibody-based or cellular-based. Those are the way we categorize them that are there. By far and away, the most common are the garden variety allergies that many of us have, whether it's pollens, whether it's fall and spring allergies. I mean, they're so common. So, and the question is it rapid? Is it immediate? Is it subacute? Or is it delayed? When you get to delayed, now you're getting into something that's cellular mediated by definition. We'll get to what's significant. So the type 1, the typical allergies immediately after contact with something that's an allergy. And again, it's usually pollen, plant products, cat dander, animal dander of different types. And not everybody's affected equally by this, certainly. The initial contact is this. It's just like anything else. It's a sensitizing dose. What happens is IgE against the antigen, binds again to those mast cells and basophils. They release histamine, sometimes heparin. It depends on where they're located or clustered and how many, whether or not you're dealing with anaphylactic shock, the worst possible thing, like somebody, and that typically is confined to people with allergies to stinging insects and nut oils. Nut oils are a big deal. So I mean, as you get into when you go into the stage of your life when you're having folks over and holidays and things like that, try to be as cognizant of that as possible with stuff that you are. I mean, I have a ball with it, but we used to have everybody over for the holidays, and I've got lactose intolerance and vegans and vegetarians and can't eat this and can't eat that. Oh, it's fun, but it's an effort. It's days to prep because you really have to. I mean, I saw my sister-in-law because of a particular allergy with things that are onion or onion-like, and there's a lot of like hidden onion powder and things like that in stock. And all of a sudden, I see her turning red. It's like, oh, WTF, you know.
She's allergic to onions.
Her mother too. My wife's mom and for whatever reason, onions, garlic, that type of stuff really promotes a reach, which is unusual.
That's really because I've been people using garlic for like
Oh, all the time.
for years.
Yeah, I know.
Centuries.
Oh God, if I took away garlic from me, I don't know what I'd do. It's my flavor base for anything. Peppers, onions, sofrito, soft fry. Peppers, onions, garlic, VOO, and happy days. Please, my kingdom for an onion. Histamine vasodilation opens the blood vessels, widens them, creates that leakiness, so it changes those little clefts. Normally, it's upper respiratory, asthma if it's inhaled, and particularly if there's clusters of these in the lower respiratory area. Typically, we fortunately again have those inhale those. Remember those beta two agents that are the beta stimulant agents that are so potent, and we're able to dilate those types of things. That we talked about. So it can be local or systemic. It's mast cells, and here's where you see it's sometimes GI. The systemic response is immediately life threatening. I have only twice suspected that in patients, and they were both after injections of local anesthetic. Typically, the local anesthetic had epinephrine in it already. Every so often, you get an untoward response, even though you historically check for allergies. So, and again, bee stings and nut oils, bronchial constriction, because what happens is that it's the opposite. It doesn't dilate those bronchi, it constricts them. And then it's the bronchioles. So it's not that you can trach somebody, it's down deep inside. Vasodilation, that's the shock component, low blood volume, circulatory collapse, low blood pressure. And the epinephrine is the rapid assault as a beta, as an overall androgenic stimulant that's there, and hence the EpiPen. And these days, if they get the price under control, but I mean, that's where, and you can scroll through those just as easily, but that's everything. Subacute is a little bit different. Okay. It's typically, as you can see, immunoglobulins in plasma or in serum. The onset time is longer. That's why it's subacute. They call them type 2 reactions, antibodies binding to antigens on specific cells, etc., mismatched blood transfusion reaction. So it might seem fine. It's not something that doesn't go right away. But as I remember an anecdote I told you about the liver transplant with the blood typing, it looks like a success. And then X number of hours later, all of a sudden, we're having a full blown transfusion reaction. So as you can see, the androgens are all over the place. They form those complexes. They can't be cleared. Okay, inflammatory. This is very characteristic of lupus, where we see those antigen antibody complexes. That we see that. So is there some misformation, some irregular antigen or irregular formation of antibodies? Don't know. When we start to get, so you can see these different guys that are there. So you have the type 2 reactions, which are specifically about the blood. We watch out for those, particularly in the kidney, because they'll clog things up. The immune complex, which is still a variation of these type 2 reactions, that's the lupus aspect of it. So we begin to see, and that's why it damages. We see a lot of organs. Kidneys number one. Diabetes, the leading cause of kidney failure. Kidney transplantation. Lupus is second. Okay. After that, there's a variety of things. Transfusion reactions would be low comparatively on the list because we do screen. And then the very famous. This is dependent on helper T cells, 1 to 3 days. Classic example, contact dermatitis, particularly poison ivy. The TB test. If you see, we do a TB test, a standard TB, the Tyne test, or whatever they call it these days, and you put a little bit under the skin. If you see a reaction right away, that's an allergy to that protein. It does not imply that you have tuberculosis because it happens right away. You have to wait. It's typically 48 to 72 hours to monitor it. So if you're like my daughter and had to be immunized when she went to India, it renders that test useless because you're always going to have a positive response. That's why we didn't use it historically in this country. We were very successful up until the onset of immunodeficient diseases. Poison ivy, I have a lot of experience with that. Typically, and you saw it so much in the feet because with people wore leather shoes and sandals. If you combine moisture and leather, what makes leather attractive are a lot of resins that are released by a combination of heat and perspiration. The skin absorbs them, and you get and contact dermatitis is very specific to contact. So it's by lights like you'll see it, where the strap is between the big toe and the second toe. You'll see it over if there's a strap overlying like that at the top of the foot. Very distinctive. It's an easy diagnosis. And treatment's fairly straightforward with regard to that. And that's everything for immune from my perspective. Goodbye. Ed.
Is with like poison ivy and stuff, can you be allergic to like was it poison sumac or whatever and not ivy?
I suspect so. I think it's different. And the odd thing about poison ivy is a lot of times I get this when I was a kid. It's called a fixed drug eruption. It always broke out in the same place on my neck. If I had poison ivy, it would be right on my neck for some reason. Don't know why.
Because I never like got poison ivy or anything as a kid. And I came to Pittsburgh and golfed once, and I had the worst. Like I got poison ivy or ochre or sumac, whatever, all over my legs.
Yeah.
And I had never gotten it before. I obviously Western Pennsylvania, lived in the woods most of your life, and I never got it.
That's odd because there's a lot around here. There's a ton. We have it in our backyard. Poison ivy, those kinds of those alert. It's a lot out here. Yeah, so when you're golfing here, if you're golfing in Florida, it's more about alligators, snakes.
I'd rather do with the alligators than that because that's an inconvenience. An alligator will kill you.
Yeah, hey, look, I learned early on you don't chase the golf ball.
Oh yeah.
I'll hit another.
That's the thing I was always worried about as a kid.
I'll hit another.
When we were in Florida, I'm never getting to a fresh body of water in the state of Florida probably as long as I live.
Oh, it's good.
That's just a death sentence waiting to happen.
Oh no, I love it. Oh, the streams there are great. We have a great place to go kayaking.
Listen, no, my luck.
Oh, you're terrible. Everybody, this is a Stein aside. Where do you see the name of this place? For you fans of Game of Thrones, King's Landing in Apopka, Florida. It is gorgeous. My screen thing on the phone is from here. We love this place. Here it is. They have see-through and they have regular, these wine, like 7 miles of these things. I'm not endorsing this, but the first time my wife and I went there, you paddle out for about 2 hours and there's like an area where you can walk around. The water's only about less than 2 feet. And these other people, there's a whole bunch of folks bringing along like, those the boom boxes we used to call them. And they would stop and they would just sit there for hours, eat. They had coolers filled with this. And there was this interesting aroma of smoke.
Oh, yeah.
Not that I would recognize.
Pot on that river, Dr. Stein?
Oh, they were. I was just getting a contact high.
Gotcha.
It's all right.
Respect.
For 7 years, I did it every day when I was in college, medical school.
Dog.
And that's the place, King's Landing. Look at this. You can do the paddle boards. It's gorgeous. You can climb there. You can get out. There's like a rope swing. Oh my wife and I love it. And as long as you stay in the clear water, which you can see down at the bottom, you get murky, you got trouble.
Gotcha. Okay.
That's where those larger reptiles hang out.
Talking about iguanas, I would assume, right?
No, I'm not talking about iguanas. So actually, we may go there when we go to Florida again. We haven't gone kayaking. We have a kayak.
Why you don't like kayak to the Nagahala?
No. When we're Dr. Buxton, he and his son used to kayak over. He lives by Raccoon State Park. We've kayaked out there. It's cool. Kayaked up in Moraine,
Oh,
and over in North Park in Pittsburgh. Let's go. Okay, so a brief refresher for 18 is about the blood vessels. So just for the sake of completeness, this is when from you guys had the anatomy, but for folks who didn't, please review this anatomical stuff that you're seeing there. The definition of these different kinds of arteries that are there, capillaries, the distinctions between them, whether they're continuous capillaries, whether they're fenestrated, whether they are sinusoidal capillaries. That's really what this is about. This is the anatomy part. So 18A it reads very easily the flow of dynamics into the capillary beds that you can see here that are there, the meta-arterioles that either constrict or open, and they'll have one of these shunts, and you can see these precapillary sphincters. These are all things that control flow. Our purpose today is not to go into the distinction between arteries and veins or capillaries and things like that, or the valves or presence or absence. That's anatomical. And there's a lot of interconnections you can see. There's lots of things that don't even have a true meta-arteriole. They're just direct shunts between arteries and veins with little in the way of control. But I would take the time and review 18A, but I really want to spend more time talking about B and C, which is really the control of blood flow to the appropriate areas. And there's some misconceptions that they tend to bring out. The first one is this idea that you could increase the blood flow to the brain. You can't. Blood flow to the brain is designed to remain constant. The only time you can alter it is if it's too low, not so much if it's too high. Okay, that's there. So whether you're standing up or you're standing on your head, it's going to maintain that. That's a fairly constant flow. So it's not like people standing on their head are magically going to get more blood flow to the brain and think better. Sure.
I've heard if you're upside down for too long, standing on your head for too long, you can cause brain damage.
If there probably is a certain amount of congestion, I would agree with that. I would think so too. I've seen it done therapeutically. Way back when I was at the Vets Hospital as a student, I mean, you're trying to acquaint these soldiers who were paralyzed or partially paralyzed and were laying flat to try to be able to, and they had a lot of tilt boards that they used. It was part of the rehabilitation, but it's very interesting. So they started them down and worked their way up and then level and then gradually, even for 15 minutes at a time. So, I mean, I think there's a certain amount of truth with regard to that. That's there. So I think that is an interesting point. Oh, wrong one. 18B as in boy. Here we go. So this is the physiology part. And this is physics and I don't do physics. Okay. Basically, they look at blood flow just like we look in cardiac output in terms of milliliters per minute. Relatively constant, but it can vary based on our usage. We're sitting here now, and we've talked about it before. Most of us, minimal amount of flow to muscles. The heart's normal, the brain's normal. Most of it is gastrointestinal and genitourinary. You're in that rest and digest kind of mode here where the parasympathetics predominate. So we calculate the force per unit area on the wall, and we call it blood pressure. We express it by a pressure reading called millimeters of mercury. That's fine. Everybody knows that. Okay. And we have to use relatively large arteries, preferably near the heart. The arteries, let's say in your thigh, are sufficiently large to easily get a blood pressure. But typically, we're mostly using brachial, probably more commonly than anything else. Not the only ones you could use. the wrist ones that you see a lot, you go to the doctor, they'll put that automatic wrist thing and have you hold it here. I suppose it's useful. I don't think it's great. I don't think there's really a substitute for actually measuring it. I think the analog ones, when you're listening, to me, are more reliable than the automatic ones. But particularly if somebody has blood pressure irregularities, if it's normal and it's normal, nobody really cares. Okay. So really, it's just that's the driving force. How do we deal with it? Is in terms of the opposition, is peripheral resistance. How much it encounters against the walls, typically about the systemic circulation. We talked about it before in the blood cell unit, viscosity. The more red cells occupy a lot of space and they're comparatively heavy, okay, and there's a lot of them. The more of them, they increase the viscosity. And that means your heart has to work harder to push things around. That's not good. Okay? Not good at all. The total length of the blood vessels is important, and the diameter. And you have to understand the key word here is total. And what this is leading up to is where our blood pressure ultimately is controlled. If you go back into that first PowerPoint, when you look at the arterioles, they're the first vessel where the muscle in the wall is strong enough to completely compress the lumen. So you can shut down blood flow. If you can shut down blood flow, you control blood flow. Okay? And that's where, so you're going to see that all of this leads to the fact that the arterioles is where we ultimately control blood pressure. So the thickness or stickiness, mostly formed elements, typically red cells predominate. Certainly proteins would play a role. We don't see the proteinemia quite as much. Then you can usually find the underlying cause, being maybe a tumor or a bone marrow related tumor. First one that comes to mind is called multiple myeloma. That's where you get in the bone marrow, you get a lot of plasma cells that we were talking about before, making a bunch of antibodies. So increased viscosity is resistance. The longer the vessel, resistance. The greatest influence is the accumulated diameter. You don't have that many named arteries or conducting or distributing arteries. You got a lot of arterioles. Okay. So viscosity and length pretty much stay the same. And the way the blood flows, it's more slowly than in the middle on the wall area. So we look at these things. If the radius increases, it's physics, I'm just sharing it with you, resistance decreases. So if a radius doubles, the resistance is 1/16. Fourth power of that when we reduce it by half. So these arterioles are the player because they can dilate, and particularly when they constrict. The radius changes much more frequently than the larger, the muscular or elastic arteries. And there are more obstacles that we encounter with atherosclerotic. Those are fatty plaques associated with inflammation. And because of those disruption, it's Yakagani 101, whitewater rafting. When you have irregularities in flow, it creates turbulence. Turbulence makes clots. The whole idea of blood flow is nice and smooth, effortless. The lining is non-sticky, all that good stuff. Love it. So yeah, milkshake with it. That sounds good. I guess I take the thinner straw, it'd be harder, it'd take longer to consume it. It's like the pizza cutting it into 6 rather than 8 because I can't eat 8. That's the way I always do it. Yeah, physics. Don't do physics. So the heart pumps. Pressure results, flow is opposed by resistance. I got that. So the steepest drop, all of this was leading to this. If we look at the average pressure. The average pressure we're going to get to is a calculation called mean arterial pressure, or MAP. And not Dora the Explorer MAP. Bridge, tunnel, waterfall.
Big Dora stand.
I granddaughter, Dora, Blue's Clues, whole thing. She didn't want to watch them. I did. I was that grandparent. Oh, let's watch that again.
Dr. Stein has got an update from my father. today, happy day, as you say, happy dance. Cam Sutton on a 3-year deal worth $33 million with 22.5
To who?
guaranteed Lions.
Good. Bye.
Out of our hair, exactly. Bingo, bango, bongo.
Have fun storming the castle.
I know. My dad's so happy to text me and said that. So one of the
Oh yeah, it's. They're better off getting one of these. Get somebody who's 33.
are,
You know, it's get the
100%.
Joe Hayden effect. Get a
Oh,
couple of decent years out of somebody who actually knows what they're doing, rather than somebody who just had a good year. Moving on. So he was going to go because there just aren't that many what they consider to be talented quarterbacks. Somebody's going to pay him.
Exactly.
So how do you calculate this? I've commented on it before. The distinction between 120 over 80, the difference is 40. You divide by 3. So the idea is that roughly the blood flow is approximately, the average blood flow is around 1/3 of the way up and so that's when you hear about mean arterial pressure, which we're going to use. That's where it comes. So typically it's around 93 in most of the vessels. When we start to get to the arterioles, we can bring that down dramatically. I mean, you can bring it down from here, let's say 93, 80s at least, down to 20, below, under 40 rather, by half rather quickly. So these are the other things that are important. And as you get older, these are problematic. Compliance or distensibility, and we look at the volume of blood at any time. So near the heart, it's more likely to be pulsable. Compliance is that stretchiness factor. As folks get older, you lose that. The elastic, there's tiny irregularities that don't allow it to rebound as effectively. It is more likely to develop mini tears as opposed, and it's unlikely to repair itself. And that's one of the things you worry about. Why there's in medicine, when someone gets a little bit older, if the diastolic for someone who's like my age, over 70, is between 85 and 90, it's not the end of the world. For a young person, you wouldn't want to see that. For your age group, you know, if you want to start 80 to 85, you get over 85, you start going, what's going on here? You know, then you have to look for underlying causes that might be problematic. Okay. So systolic is basically the pressure from the aorta as it pumps out the blood. Okay. 120 usually, and that's where you get the 120 over 80. The diastolic is the resting pressure, the lowest level when the in between beats, in between pumps of the heart. It's the more important measure. It is a wonderful measure of resting tension in the blood vessels. That's why it's so important. Before an exam, your systolic goes up. You're more excited. Your heart, it wouldn't be unusual to see somebody's 120 to be 140 or 160, depending on how excited. Before a game, it would be the same thing. Okay. The bottom number doesn't change so rapidly. So we see that. I used to see that in pre-op patients all the time. I have the nursing staff come to me and go, Mrs. So-and-so or Mr. So-and-so is 160 over 85. You still want to go ahead with the procedure? You know, that wasn't high enough for me to change my mind. It was typically, well, let's wait. We'll hold it for half an hour if we can, and we'll measure again. We'll see what happens. You know, that type of thing. The pulse pressure is the difference, and the pulse is where we can palpate the distinction. Here's the mean arterial pressure. And as you can see, as it phases out as we get farther away and the vessels get smaller. And the heart, because it spends more time at rest, that's where they get that 1/3 to 2/3 relationship. There's the calculation. So this is how we look at it. And you've all done this. The vital signs, pulse and blood pressure, along with respiratory and body temperature, are a very quick snapshot into overall health. The radial pulse, easy because it's pulses that are right on the surface are easy. It's by far and away, to me, the two easiest are the radial pulse. You can almost put the vessel between your fingers and feel it. You can even see it when somebody's really, when their pressure's up. Or behind the medial malleolus on either foot. That's the posterior tibial pulse. They're easy. Easy. And where they're close to the surface, and theoretically you can compress certain points of this to stop bleeding. You see it all. Any shows where they're putting on tourniquets and things like that. You have an idea where they are. There are certain areas like the femoral artery is always a target you really worry about. If you can't stop the blood flow from that right away, somebody's going to die. They're going to bleed out real fast. So even though you don't use the superficial temporal, you can sometimes see it throbbing. That's significant. Facial, I don't use, though. It's really sort of at the crook of your chin, that angle of the jaw. The carotid is really roughly in that area. That's what you typically use at the bifurcation of the common and internal and external carotids. We use for CPR. The brachial for blood pressure. Radial. Femoral is an important access point. We used to do a lot of catheterizations. That was an insert point. We had arteries or veins. For arteries, that's how you would introduce a catheter to do. We used a lot of invasive techniques to inject dye. Now you can still do that therapeutically. And you could introduce a stent. That's where they would do it today. And you're able to get something that's radio opaque that you can watch radiographically as you place it in the appropriate area. Popliteal is a hard pulse behind your knee. Posterior tib is easy. Dorsalis piece is kind of hard. Particularly if there's, it's just hard. A lot of times you put too much pressure on it, you flatten it out and you miss the pulse. 3 different ways to measure. Most common, oscillatory. You'll listen for the sounds. You can observe and watch it oscillate. That'll give you the range. And you can do it by palpation, but palpation will just give you when it starts, the top number. You have the cuff, as you watch the number on the cuff, and all of a sudden when the pulse starts, you go, aha, that's systolic. So a lot of times when you can't get it, for some reason you're shocked, they'll say the blood pressure was 80 palp, which meant the only way they could get it by palpation was only 80. That person's in trouble. That was me going into intensive care. So that's the fancy name is the carotid cleft sounds. Don't care. Okay, don't care. This is the idea of what makes it go. When you get to the capillary beds, the pressure on average is down to about 35 for a typical capillary bed, 17 at the end. So if the blood pressure was too high, it would tear through the vessels, which are fragile. They're permeable. And so the idea is it's the mechanism, is that pressure differential is what drives the bus. So high pressure to low pressure is able to overcome whatever pressure there is in the tissue to provide a net exiting pressure at the arterial end. And because once the fluid leaks out or extravasates out the openings, now the blood pressure goes down enough that it goes below the tissue pressure. So now the drive at the venous end is to bring it back in. So at the top, oxygen, nutrients. At the bottom, at the end of the capillary bed, waste products, carbon dioxide. Happy dance. Well done. I keep telling you, you gotta tell the design people they're doing their job, or entity. Well done up there, sir or madam. I try to be politically correct. Never. So venous pressure doesn't change a lot. It's relatively constant. It's only about 15. So that's the distinction. When we cut ourselves, it's a vein near the surface. And it just oozes blood. I mean, you'll know the difference if you get arteries pump. We call them pumpers in surgery. So this guy's, it's pumping. And the color of the blood is different. It's very, very distinctive. That's scary. You start clamping those little pumpers off. So all of these, there's a lot to it. And they're going through all this. These low pressures due to cumulative effects, blah, blah, blah. Different ways the venous pressure. Okay. Muscles themselves, particularly in your ankle and your calves particularly, are the most potent. The lower extremity, abdominal muscles, chest muscles in the upper extremity. Those basically working on the veins, as long as the valves work, helps to pump it. It's almost like a siphon, as you would be siphoning fluid out of one vessel into another. And because you're trying to offset gravity. Like we'll fill gas cans. Johnny used to get the gas and you'd fill the cans and we fill the cars with them periodically, or the lawnmower. And we use an old standard hand siphon pump that would work. So respiratory changes in breathing Okay, this is the abdominal musculature. They squeeze where the thoracic ones expand because you think of what you're doing. You're contracting the abdominal muscles. You're expanding the chest muscles. There's sympathetic action that's there, and to me, it's a really good illustration of what it's like. So it goes from station to station because of the valves. So we call that segmental movement. Number one, and number two, because as long as the valves work, when they close, it can't go back. It's not like you're going to lose it. It's not like you start to climb on like a climbing wall and all of a sudden you lost your grip and down you went to the bottom. That's start all over again. So every time you go up a segment, the valve protects you from falling back down. That's the beauty of having valves that works. And why don't valves work all the time? Injury, hereditary factors, underlying problems with valves like phlebitis, which is inflammation or damage to them, blood clots, you name it, there's a lot. So all of these, and this is where they look at the regulatory components, and it's very interesting. It's again, these are brainstem functions that we don't have conscious control over. Can we lower our blood pressure with meditation? Certainly. Can you try to relax yourself? Something you find to do very relaxing probably will help. If you're able to, medications this we use mostly more than anything else. I would think for people with high blood pressure. So what are the factors we look at? Cardiac output, peripheral resistance, overall volume of blood. Okay. For years, the go-to was blood volume. We used diuretics. The problem with diuretics, I think I told you before, is, and I know the MCAT guys I talked about before, is they induce you to urinate more. So you lose water. It's all about water. If you get rid of extra water, it's going to lower your blood pressure. The trouble was, until you learned to tolerate them, there was a lot of frequency. You lost a lot of critical electrolytes. There were problems associated with it. When I started getting treated for blood pressure, it was with diuretics. I see 2 patients have to run to the restroom. It's never good if you don't go to the restroom. So I know. Here, stroke volume, heart rate, resistance. Okay, back to the controls. I don't want to do the math. Too hard. Dr. Buxton told me he just had a really bad cold. I think it's because Liverpool lost to Bournemouth, but I'm just thinking. But I was kind. I didn't mention that because I know he's probably so upset. That's right. My key guy got a red card. Second red card in 3 games. He's going to miss 4 games.
Dang.
He's played 500 games in Spain, never got a red card.
Really?
Casemiro.
A dirty player or just
No, he didn't get a red card. He's been a little bold in the English game, let's say.
Gotcha.
He's playing for Real Madrid too, so it's there's a lot of nuances. It was a classic. He got the ball, his foot got on top of the ball, came off the ball, studs right on the guy's leg. If you look at it in slow-mo, it's a good red card. They're going to call that. It's funny, it happened in an earlier game, they didn't call it. You tell me. So here are the short-term regulations by nerves and hormones, and long-term regulation, kidney. The kidney's the big player still. So take a look at these things that will lead to increased stroke volume and heart rate, more cardiac output. If you decrease the diameter, increase the viscosity, increase the length, hard to do. You increase the amount of resistance. Again, you can increase the pressure. You don't want to necessarily do this. So how do we basically deal with it? By altering blood vessel diameter. So if you have a drop in volume, you start to bleed for some reason, internally or externally, the vessels will typically constrict, with the exception of the heart and the brain, normally. And yes, we can alter it by different ways to different areas. We'll get to that, just like we talked about in autonomic. So here are the neural controls. They're reflexive in nature. So you're dealing with chemical sensors. You're dealing with stretch receptors. Those are the 2 big controls. Understand that the 2 major ways I think that they control this have a lot to do with heart rate and respiratory. Because those systems, these three systems, the heart, blood pressure, and blood vessels, and respiration are all intermarried in that regard. If you alter one, it's going to impact the other two. If the lungs don't work sufficiently to get enough oxygen, the heart's going to try to work harder to distribute through the blood vessels to more areas. And unfortunately, that's going to have a negative effect over time. So there's a number of ways reflexively that this works. It's very interesting. And you can look at it in different ways. And this is when our first real discussion about pressure sensors called baroreceptors and chemoreceptors. And the two most important ones, one is located here at the bifurcation of the carotid vessels. That's a baroreceptor called the carotid sinus. It has a chemoreceptor there called the carotid body. In the aortic arch, it has a similar unit, okay, called the aortic sinus and the aortic body. The sinus is pressure. The body is more about chemicals, and they're all intimately associated. And then it interacts, of course, with higher brain centers. So clusters of remember, sympathetic nerves are about the blood vessels, not parasympathetic. So they're either going to uptick or downtick. So if they're downstream, if they're down controlling, cardio inhibitory. If they're up regulating or up controlling, cardio acceleratory. Vasomotor centers, this is that series of sympathetic nerves that control the diameter. When we look at it and it's continuous resting, we call that sympathetic tone. That's what your diastolic is. So all of those play a role in what we look at, and we classically refer to as vasomotor tone. Motor for muscle, tone for what level it's at, vaso for blood vessels. Carotid sinus, aortic arch, also some other areas. As you can see, if the MAP is high, if the pressure is high, it stimulates the baroreceptors to increase input to the vasomotor centers. Okay, and when doing so, it inhibits those centers. So it tends to open the blood vessels and reduce the heart rate. So you're reducing heart rate, you're reducing blood flow and blood pressure. Okay, and eventually you're decreasing blood pressure. If it's too high, that makes sense. Too much pressure, slow it down. If you're out there, you turn the hose on outside and it's bamming into something you don't want to bam, turn it down. Okay. So how does it reduce pressure? Vasodilation, arterial vasodilation reduces peripheral resistance. Venodilation, the veins contain lots of reservoirs, so there's less venous return. Remember, that's a really important idea of working the heart. The heart relies on sufficient venous return to maximally pump. If we limit that down, we don't pump out as much. Okay. Decrease cardiac output, inhibit sympathetic activity, simulate parasympathetic. So what happens effectively, you're reducing the heart rate. That's the parasympathetic. You're reducing the contractility. That's more sympathetic. The flip side, if it's low, what goes on? Reflex vasoconstriction to increase those factors. The big one, and I do it every single morning, when you stand up. Now, for you young people, you just pop up and you stand up. If you get older, because the blood vessels, the sensors are not as efficient, the blood vessels are not as pliant as they might be. Typically, your blood pressure is a little bit higher or more subject to irregularity, or you're on some kind of a medication. There's many. We have some underlying disease like diabetes. You develop what we sort of in the medical field we call a tilt. The fancy term is orthostatic hypotension. So in the morning, when the cat goes, let me out or feed me, which he's wont to do at about 5 in the morning, the cat's in charge. My supervisor is important, but the cat is running the house. Let's be clear. There's no question about that. And the kitty's like, and I get up, I sit up, and I stop. I don't hop up, because I'll bump into something or get dizzy. You might say that's normal for you, Dr. Stein. So when you sit up or stand, the blood pressure falls. So you have a thing called the carotid sinus. It's a pressure receptor. It's all about blood flow to the brain. The same thing with the aortic reflex, blood flow everywhere else. If they're ineffective, if the altered blood pressure is sustained for long periods of time, they tend to adapt, sometimes poorly, to hypertension. And they have one of those things I'm not going to go through. So those receptors are important to make sure that there's adequate blood flow to the brain rapidly enough. So for most of you hop out, you hear something, you jump out of bed, you hear a sound outside. It's not quite the same as you get to a more advanced age. Again, we see chemoreceptors, and in order, the most important thing that they sense is not oxygen levels, it's CO2 and pH. The big player in all of this is carbon dioxide levels. When it comes to respiration, it's the key player, carbon dioxide levels. And if we go back and we do that same equation with the carbonic acid buffer equation, if you increase carbon dioxide levels, it tends to make more carbonic acid. It increases, and that carbonic acid splits open, and what we begin to have problems associated with that. Even though it's a relatively weak acid, you're going to tend to alter pH. It's going to lower pH. Okay? So, increased blood pressure signals. So, if it detects an increase, cardio accelerate center to increase. So, if we end up with chemicals that are there, it suggests at least initially, that we have to increase cardiac output or increase vasoconstriction. Those are the types of things that we see when there are irregularities that are there. Higher brain centers. The medulla is really the sort of the sponsor of all of these. The hypothalamus and cerebral cortex can certainly modify it. The hypothalamus plays a role, as you might suspect, during stress, the release of a variety of epinephrine and epinephrine-like substances that are there, etc. Hormonal controls. So they work two ways, short-term and long-term. Short-term, mostly peripheral resistance. Long-term, more about blood volume. And as you might suspect, we're going to get into the renin-angiotensin-aldosterone mechanism for the first of like 3 times. We do it in blood pressure, we do it in respiratory, and not to be outdone, we do it in kidney. So a word to the wise is usually sufficient. This is something you're going to see in future tests. I don't see a lot of enthusiasm. Moving on. So if the autonomic nervous system triggers epinephrine and norepinephrine from the adrenal medulla, we know it's stimulatory, cardio output, vasoconstriction. Angiotensin, particularly angiotensin 2, that's a Roman numeral 2, vasoconstriction. Antidiuretic hormone, vasoconstriction. Okay, as well as limiting fluid, it also triggers vasoconstriction. And the guy that's working in the opposite, when there's too much fluid to balance it out, is that ANP, atrionatriuretic, excretes sodium in the urine, peptide, and it's sort of the anti-aldosterone that's there. So you can see all of these nicely in the table, where they're effective, etc. Those pressure receptors are only useful in a limited sense. When there's long-term problems associated with chronic high, mostly, and sometimes chronic low blood pressure, it's at the kidney. There are 2 mechanisms. We're going to explore that again in kidney, but I'll just give you the quick chat here about it. They're called direct and indirect. The indirect is that renin-angiotensin-aldosterone mechanism. The direct mechanism is an auto control mechanism. It's based on fluid, and you guys will recall from anatomy, the fluid flow through the glomeruli into and out of the glomeruli by way of the afferent and efferent arterioles, the wide afferent and the more narrow efferent. They're arterioles. We can control that opening. Most of the time, your kidney controls itself. If your blood pressure is relatively normal, I mean, to be abnormal, that map has to be very low or very high. In between, your kidney takes care of itself. When it's excessively low or excessively high, that's what we have. The direct mechanism being controlled by those arterioles, independent of hormones. Effectively, what happens, if you have increased blood pressure that's sensed by stretching those arterioles, what it tends to do is they open wider going in, close more going out. The fluid stays in the glomeruli longer. That generates more filtrate. The more filtrate you make, proportionately, the more urine you make. The more urine you make, the more you excrete. You're going to lower the fluid. So effectively, they're doing it. It's a fluid balance mechanism. If it's too low, it's the opposite. We'll make it go through the glomeruli faster, less filtrate, less work for our kidneys, keep the fluid in the system. Okay. There's a lot of things that interfere with it, as we'll go into. So it shows you the direct mechanisms, whether it's a decrease in arterial pressure, decreases filtration, decreases urine, increases blood volume, increases the pressure. When we get into the indirect mechanism, if the pressure is too low, if this hasn't controlled it, okay, as you can see, those baroreceptors, we're going to take them offline. Sympathetic nervous system is going to play a role. Most importantly, it's going to sense that we have to elevate blood pressure. You remember we looked at it anatomically, that JGA, the juxta, which means next to glomerular apparatus. That neat combination of pressure and chemical sensors, and that end up, when necessary, particularly in the onset of low blood pressure, releasing renin. Renin is the chemicals directly secreted. It's a hormone, goes right into the bloodstream. What it does is it catalyzes a protein that's in its inactive state, angiotensin ogen. You're going to be sick and tired of ogens from now on. When we get to digestive, you're going to be inundated with ogens. We even call the hormonal substances zymogens for enzymes that are in the inactive state. We activate it. It activates it into angiotensin 1, which then typically in the lung, maybe a little bit in the liver, is activated by another enzyme called angiotensin converting enzyme, or ACE. We use the term ACE because you can use that for acetylcholinesterase inhibiting enzymes as well. Okay, so in the context of blood pressure, kidney, circulation, ACE is angiotensin converting enzyme. We're talking about the brain, different, or neuromuscular. Angiotensin 2, the active form. Blood pressure medicines typically work in this area. The most common blood pressure medicines, of which I take 2. One is a calcium channel blocker. It works on smooth muscle, which is what blood vessels are made out of, to block the calcium so they are not as taut, so they relax more. And the other works on this pathway. It's called Cozar. The generic term is losartan. There's a ton that are in this pathway. Okay, a ton. The reason why we utilize them so much is they really have very limited side effects. You can take them every day of your life, which a lot of people do with high blood pressure. And as long as it's controlled, the side effects, for the most part, are comparatively minimal. Okay? So good medicines don't have a lot of side effects. What does angiotensin do? Angiotensin 2, the activated form, do 4 things you must know. 1, works directly on the adrenal cortex, we talked about, releasing aldosterone. Aldosterone, basically, what does it do? It puts little things in the distal convoluted tubule in the collecting duct, little openings that bring in sodium. And then once again, Stein's Mary had a little lamb rule: where sodium goes, water is sure to follow. This is usually I do my let's get the flock out of here joke. Shut up. Nobody cares. Antidiuretic hormone, we mentioned that before. It leads to the release of ADH. Okay, that specifically targets water. It also plays a role with blood vessels, but more limitedly. Increases your thirst center in the hypothalamus and directly, as its name would suggest, tensing angios, tensing blood vessels. It tightens up the blood vessel, increasing peripheral resistance, increasing pressure. Know those four things. You must. Here they are. Arterial pressure low, renin enters the blood, catalyzes angiotensinogen from the liver to angiotensin 1, and then particularly in the lungs, less so in the liver, to angiotensin 2. Aldosterone, ADH, thirst, vasoconstrictor. Big, happy dance. Important term, perfusion. We want to see things from a medical standpoint well perfused. When you do a transplant, when you take off the clamps, okay, when you do a bypass graft, what you want to see is the structure pink up. That means it's well perfused. Perfusion means there's adequate blood flow for its need, has a normal color that's associated with it. It's such a critical term. The opposite of perfusion is ischemia. It doesn't have enough. So we like things that are well perfused, and we don't like things at all that are ischemic, that are there. So in the brain, as you might guess, if you don't have enough perfusion, typically what's going to happen, you're not getting enough glucose and other things that the brain needs to run on, and you'll lose consciousness. If it's too high, now you're putting an over elaborate stressor on those blood pressures, and they are likely to tear or be damaged and lead to a stroke or clot because of the excessive pressure that's there. So voila, they summarize all these factors that are there. So muscles and respiratory pump, increased venous return, atrial nature, release of ANP, conservation of sodium and water by, that would be, the ANP is incorrect. That would decrease blood volume. So they have that graph all wrong. Losing blood certainly would be part of it that are there. Crisis stressors, and this is what happens a lot. In critical events, a lot of problems occur that are there. And now we talk about the tone, dehydration, body size plays a role, etc. We transiently alter our blood pressure for all types of things. It's not unusual. I say it all the time. Blood pressure is a snapshot, just like anything else. When you're taking your sugar, it's a snapshot. Taking your temp, it's a snapshot. When you have a snapshot, you really can't tell what the hell's going on. So you need to monitor it constantly or periodically. And that's what we would tell patients to do that and just mark it down. Got up in the morning, checked my blood pressure. I had breakfast, checked it again. Had lunch, checked it again, etc., etc. Make a map of those, you sort of keep a log of those events, so to speak. So all of those things are part of it. The classic definition for other than very older individuals or people with other types of problems associated, 140/90 or higher. Sustained means it just doesn't go below that. Like normally during the course of the day, you might take an average and try to figure out what it is. Adjust it for events that are happening during the day. Well, I watched TV all day. Your blood pressure shouldn't be over 140/90. Okay. If it's not there, then we look at, it's like pre-diabetes. It suggests that there could be something going on. It could be, stress situations, emotional situations. Okay. we see it more. People who are heavier in general, blood pressure is a problem. When I weighed somewhere between 260 and 280 when I was 20, big fellow. I think my diastolic was over 100. What changed that is when my old family doctor said, "When can I book in for your stroke?" He wasn't subtle. So, all the things. What's going on with blood pressure? You're putting a strain on your heart. You're damaging the blood vessels. You're clobbering your kidneys trying to keep up with it. You're so much. The heart enlarges. And again, it's not one of these muscles that works better when it's overly enlarged. It doesn't have a big enough chamber. It can't pump as effectively. Over time, it weakens, accelerates damage to the blood vessels, which leads to atherosclerosis, fatty deposits, and eventually calcific deposits, quote unquote, hardening of the arteries. Sclerosis means heart. So most of these are under hypertensive or primary hypertension. So most people with blood pressure problems, this is where it comes from. We don't really have an underlying cause. We look at risk factors. Most of it's behavioral. Okay. Heredity, well, you can't control that, but diet, the amount that you weigh, can't really control your age. Diabetes, you can treat. Limiting stress, smoking, and other environmental things. Certainly. Dietary controls, all those types of things. Sir.
Are you guys paying attention?
Yeah.
No. You're
No,
not.
no.
Yes.
On Saturday, there is an admitted students' day. Are you working that day? I'd love to have an upper level non-environmental biology student come over and just be there for students to ask questions. Who are we gonna have come over?
Is who, Matt?
Is that not me?
Oh, Dr. Stein, just remember.
I have a question. You'll stand at the table.
Yeah, Matt.
What time is it at?
I'll get you details.
Because I
Oh, they're giving you pizza too, by the way.
Matt's in, man.
I have an online class on Saturdays.
Look, she won't even make eye contact. Nope.
Annabelle, she likes talking.
I know. Non-stop. Chatterbox.
My game's on Saturday.
Sure. You could be sick.
Alright, it's looking more and more like it's gonna have to be me. What time is it?
I mean, have to.
I'm the only one left. I'm the only one left.
He said, Matt said maybe.
He has his class though.
Greg hasn't said anything.
I work that day.
You worked that day. Justin would not even make eye contact. He just kept his head down.
I can pop over.
Oh, Dr. Stein.
How long do you have to stay?
Jimmy G signed with San Francisco.
Did. When's his
I'll take it tours
class?
and everything.
Raiders. I mean,
Well, it's during the event where they bring them over
Am I
here.
able- Like, go to
You're not busy
I'm
walking
Dr.
people in
Badger
different
for that,
rooms.
except the students thing. So
Okay.
Let me know details, and I will get back to you if our game's good.
Yeah. If not, I don't plan on doing anything Saturday. So if you
All
do
right.
need,
Maybe I'll send you for an email. I'll send it to Justin too, just so you can delete it and feel good.
Justin senioritis, Dr. Badger, he may not even show up the rest of the year. He may be out of here.
All right, sorry to interrupt.
No, feel free, please. We're talking about blood pressure.
Please.
And these guys raised mine.
Not you though.
I know. Moving on. So,
You do.
as you can see from all of these things, a lot of this is controllable. I mean, it's the hardest thing in the world to do our lifestyle changes for a lot of people. The best advice I can give any of you guys, because it doesn't strike me as all you guys should be relatively healthy. Not good. Not great, but healthy. Is don't get unhealthy. You know, try, yeah. Do you see a lot of cigarette smokers these days, you guys? No, probably not.
Those vapors and shoulders.
Yeah, I understand. I understand the vaping thing, which is problematic. Nicotine's not fun and games. But I don't see a lot of that. And most of you guys, and most of the students that I know, we work
so I
out.
should not do swishers in the bathroom.
What?
Never mind.
Pop culture reference. I don't understand.
kind of funny. It's what kids would do in high school. They buy the cheapest thing called the switchers, and they're smoking in the bathroom.
Oh, okay.
At mine.
God, I miss this stuff. Sorry. Moving on. So that's basically that's the longest. Secondary hypertension means you can identify: is it kidney disease? Is it some primary? Is there some underlying disease that you can attempt to control? So you look at the underlying disease. That's secondary. The primary, by far and away, predominates. You don't see a lot of hypotension. A lot of people are great as hypotensive. My wife, most of the time, when she blood pressure be 110/60. It's not unusual. Not unusual. It's low blood pressure is typically a good thing. It's typically something you want to be on the low end. We're not talking about critically low. This is the orthostatic. A changing position. Other things when it's chronic, and you have to look for underlying diseases. And then when it's acute, that's a real problem. When we look at acute height, when somebody's losing, like what happened to me. So I was all of a sudden I had endotoxic shock. So I was vomiting and diarrhea related, and all the things that were going on because of the salmonella infection. So that was a kind of circulatory shock. Then you have to treat the underlying disease and support the condition. They go over these different shocks. So it's worthwhile talking about. So where the blood vessels effectively is not meeting the needs of a specific tissue. So the question is, why is it there? Is there not enough volume? So where does blood loss come from? Blood loss less often comes from big traumatic injuries like a car accident or an explosion, that sharp force trauma or major trauma, more often from internal bleeding, which is part of the problem that I had when I had a lot of things going on. This was not a particular time when I went into intensive care. Vascular shock, extreme vasodilation. Again, that's probably went along with what I had a little bit because of the gram-negative sepsis and gram-negative infections that get in you. That lipid A, that's the endotoxin, that's kind of what it does. One we see a lot of, and it's never good. If someone has a heart attack, it's called cardiogenic shock. People go into this, it's a bad outcome from a heart attack. That's one of the things that really is closely associated with fatal heart attacks. Cardiogenic shock. Voila, that's done. Hey, we're nearly there. We're nearly there. We're not there yet. Later awake out there. Respiratory system. This is the molecular part of it. You've had a lot of this with cell and molecular and stuff like that. I'm not going to go crazy with it. Okay? It's about hemoglobin. It's that wonderful saturation curve that you're all familiar with. I'm sure Dr. Hilwig hammered that in and all that, the S curve. Just saying. Oxygen is mostly, there's a little bit in the plasma, okay, because it's a gas. Mostly it's bound to the iron component of the hemoglobin. We know that. Okay, we know the structure of hemoglobin, whether it's oxyhemoglobin or deoxyhemoglobin. It's just basically a reversible exchange for the most part. Okay, change in shape of the hemoglobin. And that's the interesting thing. Because of that shape change, that creates that interesting curve. It's one of those, it's a good news, bad news thing in the body, that S curve. We're able to maintain it. If there's subtle alterations in oxygen, it isn't a big deal. But when it starts to really go down precipitously, it's like you're at the top of the water slide and boom, you're going. I mean, for instance, where do we monitor pulse ox a lot? People in hospitals, nursing homes. So if a nurse's aide would come and say, oh, I remember my wife telling me one time the nurse's aide didn't come to her. She was the LPN on charge of that part of the floor, and tell her that Mrs. X's pulse ox went down to 89. That's a big deal when it was like 93 the day before the last shift. I mean, she's potentially going into a crisis because it's the slippery slope effect that's there. That's why pulse ox is so interesting. I'm going to probably bring that in. We do the respiratory and do the pulse, we have like a pulse ox detector and things like that. The trouble with you guys are too healthy. I need sick people physically. So the more oxygen it attaches, it enhances its oxygen. The more it releases, it enhances its release. That's the beauty of that molecule, and that accounts for the curve. Okay. So typically, when we have deoxygenated blood, it's really only about 25% of typical venous blood. So 3/4 of it is still fairly well oxygenated, but we call it deoxygenated because it's not fully saturated. So it's all about the rate that's there and the factors. The pressure of oxygen, temperature, blood pressure, PCO2, this BPG. That's important, and that plays a role with association disassociation. Always have to look that one up. Okay. Okay. Percent of hemoglobin saturation against PO2 in this non-linear or oxygen hemoglobin curve. You've seen it 1,000 times, and that's the point. When you're getting to that, like I said, when that lady was up at 90 or 92 or 93, you're not having a problem. But when they start to go down, they're right at the top of that slide, like you were when you were a little kid, and the next thing you know, you're at the bottom. Just wait till you have children if you want to have children. Not that I would recommend that. You know me. Down you go, and you can see what happens. So, as you can see, PO2, 100 millimeters of mercury, 20 milliliters of oxygen, blah, 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 fully saturated. Okay, we can increase it. And as you can see, 15 volume, it's still 75%. They call that the venous reserve. So even if your heart would be near stopping or particularly sluggish, it's not, you have a certain window of time to get stuff. So theoretically, somebody who went asystolic, if their heart stopped, I mean, if that meant that there was all of a sudden there was effectively no available oxygen, they would die immediately. We know that's not the case. Depending on other factors, you have like 3 to 6 minutes to be able to restore it. And yes, it differs depending on activities and depending on your location. We know that. And that's part of this. So increases in temperature, increases in acidity and lowering the pH, and that associated with increasing PCO2 and this BPG, which plays a role, which we'll get to. In decrease so we begin to see that the BPG is typically produced as oxygen goes away. That's part of the ways in that it facilitates the release of the oxygen. Okay, we see it in the capillaries, it enhances unloading, it allows it to shift the way it's supposed to, and the opposite occurs to reload it. We see the situation change. So you can see what happens at body temperature. Okay, cold temperatures, a little bit different. It holds on, where at warmer temperature, it releases more quickly. Okay. Carbon dioxide levels. Okay. So as you can see, when we have carbon dioxide levels are increased, okay, because you can see how it holds on to, but as the pH begins to drop and we get somewhat acidotic, it allows it to unload more rapidly, which may be good up to a certain point, but it's problematic long run. The BPG, right, RBCs during glycolysis, when oxygen levels are low, they use the oxygen. Associated with that are increases in PCO2 and acidity. Declining the acidosis, the increasing PO2, weaken that bond between the hemoglobin and oxygen. So effectively, the beauty of that system, and we see the reverse of this when we get to respiratory. This Bohr effect, and if you learned about it before, it's good to learn about it again, facilitates oxygen to where it's lowest. So that's I say about it all the time. There are all of these things. The MCAT students I talked about in kidney. If you have 1/4 of one kidney functioning, it's like it's normal. When that goes below that, all of a sudden now you need dialysis or a transplant. These are backup systems that are designed to accommodate for periodic changes, infections, odd situations that might occur, ingestion of a chemical, a toxin, an unusual reaction to a medication that could mess things up. What happens here is under normal circumstances, when there's an area that doesn't get enough oxygen, it's going to unload where it's needed the most. Okay? Heat production. If it's a busy tissue, decreases hemoglobin affinity for oxygen and more unloading that occurs. So it's a really good thing where we see where there's an acidotic area or too much CO2, a damaged area, if you want to consider it that it goes there. It's a good thing. How does this is important? This goes back to this idea of why carbon dioxide is so important. It's not as though, here's how I was taught. Gives you an idea what we learned. It's like the oxygen was riding on the hemoglobin. When it goes to the tissues, the carbon dioxide jumped on. It's like you got off the bus and somebody else sat in your seat. Nothing could be farther from the truth. As you can see, some of it dissolves in the plasma. It's a gas. The vast majority of it, 70%, participates in the buffer. The other 20% rides on the globin. It doesn't have anything to do with the heme group. So it's a totally different system in that. It's bound to the globin. We call it carbaminohemoglobin. The 70% is all about that magical buffering system. Again, weak acids make great buffers. Weak acids, it's the way I always express it. It can give up a proton or not. Yeah, you want a proton? Have one. Hey, you got a proton? I'll take it. WTF. Yeah. We're open for business. I love that. Carbonic anhydrase, an important enzyme. Typically we see in red cells. That's the one that allows that reversibility. It allows the carbonic acid. Once the carbonic acid forms, it can go where it has to do. Why is that significant? When we get to respiratory, what makes carbon dioxide so critical is our need to breathe is in the central nervous system. There's no carbonic anhydrase in the cerebrospinal fluid. That's why carbon dioxide is the critical factor for breathing. Anybody dive? If you do scuba or free diving, if you do that stuff, how you do 3 deep breaths and you purge out the carbon dioxide to try to max out your free dive. As kids, who could stay underwater the longest. Didn't know that. And so I'm sure I never could do scuba diving because my ears, like they are now, are really clogged. I had so many ear problems as a kid. My first wife was a certified scuba diver, so she did all that stuff. They took her up to it was like a mine, like a mine shaft that they filled in. And they it's called ditch and don. So they throw all the equipment at the bottom. You got to go down there, find it, with just your mask and your flippers on, put it on, get your radiator working, and come back up. That's your field test. How's that?
I want to do that in Florida, like we said, in the murky waters.
Yeah, we're up in Erie. There's not that many alligators in Erie. The only alligators that are close to Erie are in Meadville at Allegheny College. They're gators. So, we're going to visit this bad boy again. You're going to love this. We're going to see it in digestive. It's called the chloride shift. In the systemic capillaries, with a bicarbonate ion is created, it diffuses from red blood cells into plasma. That's good. Okay, it has to balance by chloride moving into the plasma. It's one of those ways. These chloride shifts are neat things that we see in respiratory and digestive. One of the things it does is it facilitates the formation of hydrochloric acid in your stomach. And we're going to get to that in digestive physiology. So they're showing it to you here. What happens, how it goes, how the oxygen can go out into the tissue, how the carbon dioxide can come in, how the chloride shifts to balance out the bicarbonate, as effectively it goes out, kind of, all those types of things. In the pulmonary capillaries, it reverses itself. It moves back in, and the chloride moves out of the RBCs back into the plasma. Okay, fine. And then as you can see, it reverses it, finds the bicarbonic acid, and then the CO2 in the water, and we can get rid of the CO2. It's neat. So that chloride shift facilitates the eventual expulsion of the exhalation of the carbon dioxide. So it's important as well. The Haldane effect. This is one of those things. It's like it's similar to the Bohr effect in the sense it has to do with carbon dioxide release. It's affected by oxygen saturation. The lower the PO2 and hemoglobin saturation, the more CO2. Okay, reduced hemoglobin without the oxygen buffers the hydrogen ion and forms carbaminohemoglobin more easily. Encourages CO2 exchange both at the tissues to bring it in as the Bohr effect occurs. That Haldane effect helps to bring in. So Bohr, oxygen going out, Haldane coming back in. So as the oxygenated hemoglobin releases it, it bonds more readily with the carbon dioxide. So that's the beauty of that system. And you're going to see when we get to respiratory, there's another way that carbon dioxide goes to the areas of the lung, not where it's needed the most, but where the passageways are most open and you can maximize ventilation. Again, another good design. Here's the buffer. And of course, we consider the bicarbonate as these quote unquote alkaline reserves. And it can go in either direction. If you have too many hydrogen ions, fine. We can remove those by combining them with bicarbonate and disassociating the carbon dioxide. What do we do? We breathe it off. We exhale. When you're working out, what do? Okay, you're exhaling more. You're breathing faster. You're expelling carbon dioxide. We all do that. It's what it's what aerobic exercise is, marrying your degree of activity to your heart rate and to your breathing so you can do it for sustained periods of times that are there. Slow, shallow breathing increases CO2 in the blood and increases acidity or drops pH. Rapid breathing in the opposite direction. So we can alter those and impact our acid-base balance. When we get to respiratory, it's one of the reasons why we tell somebody if they're hyperventilating, the key is, other than using the paper bag, we want to encourage people to take slow, deep breaths. You can really maximize the outflow and the inflow under those types of things, and I'll show it to you. So what happens? This is when we start talking about insufficient oxygen, hypoxia, too much, not enough. And cyanosis is when effectively there's not enough oxygen, there's an abundance of carbon dioxide. It leads to the characteristic discoloration we see in lips and fingertips, in other areas, in palms and the soles, that suggest that we're reaching a critical point where that person could go into cardiac arrest. So is it red blood cell related? Is it a blockage? Is it have to do with a poison? Does it have to do with a ventilation problem? Or is it carbon monoxide? What's causing the lack of oxygen? Not enough red cells, no way to get there, something in there that's a toxin. Most of the classic cyanide, strychnine work on, if you did not know, on the electron transport chain, they block that so the oxygen eventually can't get there. And they work very, very rapidly. So I read a lot of Sherlock Holmes stuff. Hypoxemic, okay, that now you're dealing with something that's ventilation, carbon monoxide. The key with carbon monoxide, here's how they used to tell us. Well, the oxygen would get off and the carbon dioxide would get on. Carbon monoxide is the one that does change places. If you look at it structurally, O2 with a double bond versus C with a double bond is actually a better exact fit on the hemoglobin molecule. Once it gets on, it don't get off. It permanently damages the hemoglobin. Thankfully, we get rid of red blood cells over time. I smoked for 40 years. There's plenty of carbon monoxide in that. Carbon monoxide poisoning if you do, if it's done in short term, is fatal. You know, people who want to do themselves in and start the car with the garage closed, colorless, odorless, painless. You know, you can have that kind of a situation. It was the early gas that was used in the gas chambers. They used it as buses that didn't have an exhaust. You didn't know that. Just a little topic on the Holocaust. One of those. And this is one of the little tells that you get because it's colorless, odorless. Is headache, and what characteristically what an emergency worker would see if they see carbon monoxide poisoning, they see a pinkish appearance. When they see that, that's the first 63 things you think of. Carbon monoxide. What do you have to do other than get them on oxygen? The best way, if you have a chance, and the same way with a fire, with a firefighter, or somebody's in a fire, that's when they use hyperbaric oxygen. You put them, you're trying, it's not so much forcing it, it's trying to maximally oxygenate all the cells that aren't damaged. It's really not, you might get rid of some of the carbon monoxide, but not a
Is
lot.
that why athletes use those hyperbolic chambers to force oxygen into their muscles to recover faster?
Yes. So, I mean, the hyperbarics can have problems, particularly in little kids. There are problems, and they're all, and when we get, again, into respiratory, you talk about the bends from pressure, which you're basically simulating being at depth diving, and typically you get the bends when you come up too fast. What happens is nitrogen, which is a gas that gets forced in, if you come up too quickly, the bubbles come out and basically block blood flow. And that's where the bends, so you have to bring them back down, put some nitrogen back in, and slowly, that's, when somebody knows what they're doing diving, they have decompression schedules and things like that. One of my, he's dead now, his son and a variety of associates, Clive Cussler. I read every single book. And it was all about, it was just brilliant stuff about stuff that happens. These are just wonderful reads. Maybe they're a little dated, the older ones. They're just brilliant, brilliant. I don't know if that's worthwhile or not. These are the controls. I'll take a look back at that. You've been forced to listen to me ad nauseum. Hold on, let me answer this. Don't have children. Higher brain centers, this is the controls that are there, chemoreceptors, other reflexes. It's basically, there's two groups in the medulla, ventral and dorsal, that really, they generate the rhythm. And yeah, I mean, I don't really care about that. And then there's also a relationship with an additional grouping in the pons. And basically, it's like a metronome. They set the rate. So you can have the normal respiratory rate and rhythm, and basically they just alternate by basically playing a role with the phrenic nerve and the intercostal nerves that are there. So you can see these are the dorsal ones are controlled by cranial nerve 9, the glossopharyngeal, stretch receptors, chemoreceptors, etc. Not a lot of information in the pons. Smoothing out the transition between input and output that are there. So it's understood here. You can see in the medulla and the pons, these groups are sort of interchanged to control that. Again, it's a pacemaker type of a theory, which means we're not sure how it sets the rate. We don't even think about it for most part. And then all these other influencing factors, chemicals, higher brain centers, irritants, etc. No question about it. PCO2, I think, is still the big player. O2, pH, all three of those. The chemoreceptors all throughout the brainstem, the peripheral in the aortic and carotid arteries. They call it, in the old days, aortic bodies and carotid bodies. PCO2. What in the brain is the big problem. When it forms carbonic acid, okay, effectively what happens is it lowers the pH. It's not reversible in the sense of it's not reversible by way of carbonic anhydrase. And so the only thing you have to do is to try to expel it. So that's why it's such a potent force on getting you to breathe that are there. Stimulates chemoreceptors, etc. increase depth and rate of breathing, and they in that way they'll lower PCO2 and bring the pH back. So basically, it's about expelling CO2 to try to eventually get that system back to normal. Okay. If it's decreased, okay, respiration becomes slow and shallow that are there. So this is the idea of swimmers voluntarily hyperventilating because it eliminates that need to breathe. But there's problems that can be associated with it too. So it's really a fine line that I'm not that familiar with. This is that interesting one about, usually it's from being excited more than anything else. Some people are just prone to it, anxiety attacks. So you're blowing off so much CO2, cerebral vasoconstriction, dizziness, ischemia, fainting, spasms, and it's the idea is you're basically forcing the person to breathe in CO2 rich, and it works. There's no question it works. That I've never seen it myself. I've seen it in an emergency room, but I've never had that. The chemical factors, the aortic and carotid bodies are about O2 levels. Not a big effect, as you can see, because we have so much O2 that's still bound to the hemoglobin. If your PO2 is getting down to 60, big trouble. Okay, the way I look at it. And there you can see the locations in the aortic arch or the aortic area and the bifurcation of the carotids. Arterial pH plays a role. Okay, some chemoreceptors, lactic acid, ketone bodies. Okay, it'll attempt to increase respiration. So again, blowing off CO2. And this just summarizes all the factors that are there. There are other controls. Holding one's breath if you're inclined to do that. Anger or gasping with pain can have an effect. I'm not that familiar with this one. Pulmonary irritants we've all experienced that. Something in the air, somebody's burning, maybe you get it from burning leaves, somebody threw some plastic in there, little particles could be an irritant. Things. The herring brewer or brower, I don't know how you pronounce it. Stretch receptors stimulated by lung inflation. So basically those receptors are telling it to, when it reaches a certain point, stop inhaling and allow it to start to exhale. It's more protective than anything else. And they're talking about that. Let's see. This is interesting too. We're almost done. Thank God. See how much is left? Not a lot. I'm proud of you all.
Thank you.
Put up with me. Even I'm tired of me. Okay, let's see. So in exercise, we talked about that. You can increase your ventilation dramatically. So up to a steady state, and you can keep this relatively constant by doing it. So there's a lot of factors that are involved. Psychological anticipation. Like literally, you'll increase your rates of these things when you walk into the gym. Okay, your body's already starting to accommodate. Activity increases it. A variety of the receptors, you start to move things around, so they'll increase the rate of delivery. And the opposite is true. So anaerobic respiration and lactic acid, but again, if you adjust, then you can continue it for long periods of time that are there. A word about altitude sickness. You're guys traveling out that way, Julia? Do you travel out that way, Denver?
We went to Washington last year, but like not regularly.
Yeah, because I got an altitude thing when we visited my stepdaughter and her crew out there in Denver, and then went up to. It was during the summer, but we went to one of those skiing resorts, but hung out there. So it was during the lockdown. It wasn't a lot of fun, but we had to use our points for the timeshare. I was fine when I got into Denver. The next day, I had a headache for 36 hours. It was all altitude. So it was this acute mountain sickness that are there. I just didn't adapt. The headache was monumental. I got to the hotel at like 3 o'clock in the afternoon. They didn't see me till 8 the next morning.
Yeah.
I just was in a dark room doing nothing. Nothing would help. Okay.
skiing the first day.
Oh yeah, it takes a while, particularly if you get there gradually, it's a little bit different. Instead, it's like flying in there though. It's
Yeah.
I mean, I love the area. It's really nice. It's always sunny. Always sunny. So it takes a while. It generally it's longer than you think. It's not a week. It's generally the better part. It's at least 2 weeks, preferably a month. In soccer, when they play at elevation for World Cup, they go a month, 6 weeks early to accommodate, to allow them to adapt. That's when we get to that whole thing with Ryan Clark not being able, because of the sickle cell trait, and ending up with why he couldn't play there. It's just there's just no way. It just can't adapt that fast. So all of those things are play a role. But eventually it stabilizes, and what it does, we over time it would increase your number of red cells. Over time, your blood would thicken, but not excessively so under normal circumstances that are there. So it stimulates the EPO, and eventually you sort of get to it. We're almost there. We're going to do these in we're going to look at these more closely in respiration, whether it's emphysema, which is a lack of available exchange space, or bronchitis, which is more of a blockage, or a combination of both those. Emphysema kind of goes over, and they're basically irreversible once they reach that. All of those types of things are there, and the number one factor, yes, ladies and gentlemen, smoking, that are there. We'll talk about this when we get to this in respiratory enlargement of the alveoli, destruction, trapped air. That's what emphysema means, everyone. The accessory muscles, you're much more tired. Breathing should be effortless. Hyperinflation, expanded barrel chest. This is what they told me this. Okay. They saw my chest x-ray when I was a smoker at 27. And the radiologist says, look at that. You've got a barrel chest now. Imagine if you don't stop smoking. You'll have horrible emphysema. Which was great because it only took me 30 years.
30 years is never too late.
Never too late. It will be 15 years, June 20th, that I stopped. So all of those. You get a lot of problems on the right side of the heart. It's called cor pulmonale or pulmonary heart. Very famous diagnosis, right heart failure. There's some hereditary factors. Chronic bronchitis from a lot of things. We're going to get into the difference between obstructive and restrictive disorders, and sometimes they overlap. We'll talk about pink puffers and blue bloaters down the road because I'm about ready to be done. A little bit more about asthma. I'll finish this up because I don't want to give a short shift. Okay, it's enough. You've had me for an hour and 45 minutes. So to all of you that stayed out there, thank you. Good night.